of this station, its staff, management, or sponsors.
Amp2.tv presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hello, South Florida and beyond, and welcome to the You and Your Doctor show, living a longer and healthier life. We're going to bring back to the program Dr. David Selzer. He's an internist. I'm going to do a quick bio on what we're up to tonight on this adventure of health. So, Dr. Selzer was nice enough to come back to the program. You may remember just last week, he talked to us a lot about his areas of interest in internal medicine. He is with NYU Langone Medical Associates in West Palm Beach and on staff at Good Samaritan Medical Center. Now, Dr. Selzer, I'm going to give this info out a few more times. And there he is, Dr. Selzer. How are you doing tonight?
I'm doing great. Happy to be here.
Thank you. And we just popped right up on the screen for the viewers, so that was perfect timing. I was just saying, you're going to be doing a lecture at Good Samaritan Medical Center. The topic is really interesting, something I need to learn more about because I really don't know it. Is anemia and chronic kidney disease?
Yes. So it's going to be on Wednesday on June 27th at noon. All are welcome to attend. So patients who have chronic kidney disease are more likely and have greater risk to become anemic. So anemic is defined when your hemoglobin concentration is less than 13 in a man and less than 12 in a non-menstruating woman.
Oh, it's different between a man and woman.
Men and women, yes. So the hemoglobin is the molecule that carries oxygen in the blood to the cells. So in order for you to oxygenate your body, you have to have hemoglobin. So when patients become anemic, they start developing symptoms that suggesting that they don't have enough oxygen in their body.
And that's when it becomes a problem, because if you don't have enough oxygen in your body, that becomes a problem with not only respiration, but there's other issues as well.
You start to feel extremely fatigued. They're not just, fatigue is not the right word. They start feeling exhausted. They feel like they can't move. They also start developing a sort of a sense of air hunger, because remember, they're getting blood to their lungs, but it's not enough oxygen there to oxygenate them appropriately. And then their heart. The body senses that there's not enough oxygen going to all the different organs inside the body. When it senses that, the heart will start to beat faster. The reason it beats faster is it's got to get the blood out to the rest of the body in order to oxygenate it. But the problem is you're pumping this fluid throughout all these vessels with not enough oxygen. So first you start to feel palpitations, and then your heart starts to get bigger and stronger in order to compensate for that, for the extra pushing that it needs to do. It's kind of like the heart becomes like a weightlifter, just trying to get stronger and stronger. But there's a limit of how big that heart can become. When that heart starts getting too big, it can either go into heart failure because it just went above and beyond what you expect it to do. The other issue that can happen is the demand for the heart itself starts getting higher and higher. So all of a sudden, this big heart is pumping blood all over the body. The heart itself starts getting tired and fatigued. And when the heart itself is not getting enough oxygen, that's when you start getting chest pain. We call that angina, and that's that pain in the chest that happens here and there, and that happens when patients become anemic.
And so first, I'm breaking it down here. So it's the heart becomes overworked.
Yes.
And the blood's not transporting enough oxygen around. I mean, the blood's flowing, but it's not transporting enough oxygen, causes fatigue, and that becomes a big issue. Is there, I know you're going to get to this, but is there an age range? Because when I did, the first thing I do is go do a Google search. I know that's not a good journalist, but nowadays, first thing, anemia, quick, I do a search. And I saw that it was like middle age to maybe the senior citizen age or older. And then as I went into journals and whatnot, I saw a little bit of more information. But is it something that normally is particular to an adult?
It definitely happens more often in middle to older age. However, women who menstruate heavily, they can become anemic. Or patients who develop iron or folate or vitamin B12 deficiencies, they can also become anemic very quickly.
Okay. Now, I know you're going to tell us a little bit about how iron plays a role in all this, because I imagine, when there's not enough iron in the blood, that becomes a serious issue.
So iron is one of the main substrates for which hemoglobin forms. Without iron, there's no hemoglobin. Therefore, you need the iron in order to get hemoglobin, in order to get oxygen to your blood. Now, a lot of times it's simply because of you're not eating enough iron in your diet, and that happens in spinach and red meat. And that will increase, if you have more of that, you get more iron. Other causes of iron deficiency are bleeding. That's why we're talking about menstruating women all the time, that they can decrease the amount of iron inside their body.
Now, could an internal bleeding be a cause of a loss of iron, or?
For sure, because you start losing blood, doesn't matter if it's coming out of your arm or coming out of your spleen. Blood's blood. It's not in the system.
If you lose it, you're losing the iron, obviously, there.
Yeah.
As well. So this is a question I wrote, and you're going to be doing a lecture. We talk a little bit about it, but again, it's Wednesday, June 27th at noon.
Yes.
At Good Samaritan Medical Center. They have that beautiful lobby in the front.
Okay.
And I know there's a room right off the side there. I believe it's probably where it will be, or in that lobby. I've been to a lot of presentations there. That's why I know. My daughter was born there. I think we shared that last time.
Yes.
Almost a year ago. Yeah, it's coming up. Wow. Now, what is the pathogenesis of anemia and chronic kidney disease? I almost got it right.
So, the pathogenesis is that the kidney makes an enzyme called epigen, and that sort of stimulates the red blood cells to form. So, first you have to have the substrate. You need to have iron in order to make the whole thing work. Then you need epigen to sort of push it through. So when in chronic kidney disease, that kidney is getting smaller and smaller and smaller. So therefore, there's less epigen for the kidney to produce. Another factor that actually happens is patients with kidney disease have chronic inflammation. And that inflammation causes an enzyme called hepcidin to stop the red blood cells from actually forming. So you have situations where you have enough iron, you have enough epigen, but because of the inflammation that happens in chronic kidney disease, the process is stopped because the inflammatory markers stop the red blood cells from forming.
I see, and that's another problem in itself as well.
So the way to treat that is just to try to heal the patient overall, and therefore improve their entire medical scenario in order to try to help them get better.
Now, is this something that you as an internal medicine physician or internist find out from labs or evaluation when you're seeing people on their preventative medicine visits or their regular office visits? Or how does this, how do you find out about it? How does the physician wrap their arms around this and get to the patient?
Well, because I have expertise, I can just look at somebody and I know, boom, anemia. But for other people...
Really?
No.
I was going to say, wow. You had me there for a second.
But for what physicians do is they check the CBC, which is the complete blood profile of a patient, and they see is the patient anemic or not, as we've explained, less than 13 or 12. Then they do is the mean corpuscular volume. They start looking at the actual size of the red blood cells. That will give us a hint as to what is the likely cause of it. When the mean corpuscular volume is small, right? So then you start thinking it's iron deficiency, because as we say, that's a substrate in order to make the hemoglobin and the red blood cell. So if it's not there, it's going to be smaller. It's called hypochromic microcytic anemia. That's the big word and the one that's hard to pronounce. You can also have what we call macrocytic anemia. That's where it's really big. So you have that in folate and vitamin B12 deficiency. The reason you have it there is because you have a DNA replication is halted, but the cytoplasm is still going. So if you don't have the folate and you don't have the B12, the DNA is not working, and the cytoplasm is going and getting bigger and bigger. So that's why the cell is going to be really big. The other issue, if you have an epogen deficiency, it would probably be called normocytic, would probably be normal size. The next step you can also look at is the reticulocyte count. The reticulocyte count is a measure of how quickly you're making more red blood cells. So in iron deficiency anemia, the reticulocyte count is usually low because you're not making it. But in other cases where something is destroying the red blood cells, the body itself wants to increase the retic count and make it go faster to compensate. Like if you're bleeding, you're going to be reticking very quickly because you want to stop that. You want to make more red blood cells in that situation.
Now, is the urinalysis part of the lab as well, or is it just strictly a blood analysis?
Well, you want to look at the urinalysis to see if there's any bleeding going into the urine, and that'll be a good marker to ask yourself, well, is someone bleeding or not? Other markers to just see, is there a bleed? You can look at the BUN creatinine. A lot of times, we always talk about the creatinine, and what is that? A measure of their kidney function. But when you also, the number above that, called the BUN, that number goes up a lot of times when there is an acute bleed. So that's another way that you can look at it. Other markers that help you tell, like maybe somebody's bleeding or not, platelet function. It's either when it's depending on when you're looking at it, the platelets can be extremely high because you want to stop a bleed, or very low because you had what we call a consumptive coagulopathy, where all of a sudden all the platelets were used up in order to stop a bleed. So those are markers that help you tell if someone had a recent bleed or not.
Now, how common is anemias and kidney disease? So you have subject A here, they're your patient. Now, they have kidney disease. Is this something that always is involved with kidney disease anemias, or some of the time, 50% of the time, or is it just hard to say that? I
think it all depends on what stage of kidney disease you're at. So stage 1 and 2, it's still like 10 to 20%. So for our viewers out there, stage 1 to 2 generally is where you're having more than 60% of your kidney function. Stage 3, you're ranging between 30 and 60% of your kidney function. And therefore, those patients, the number starts increasing until you're at stage 4 or 5, which is 15 to 30%, or 0 to 15, you're looking at 70 to 80%. So depending on where you're at in the kidney disease spectrum, that will explain to us how often you have to worry about anemia.
Now we're here with Dr. David Selzer. He's an internist at NYU Langone Medical Associates in West Palm Beach, right downtown West Palm Beach, 101 North Clematis Street, Suite 110 in the heart of downtown West Palm Beach there. Also on staff at Good Samaritan Medical Center, where he's doing a lecture on anemias and chronic kidney disease, the topic that we're doing tonight, on Wednesday, June 27th at noon, right there at Good Samaritan Medical Center. Easy to get in and out of there, and should definitely check it out if you have any questions. We're going to take a quick break and talk a little bit more about anemias and chronic kidney disease with Dr. Selzer on the You and Your Doctor show.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 2009996. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Hello, South Florida and beyond, and welcome back to the You and Your Doctor Show. We're here again with Dr. David Selzer. He's an internist, internal medicine at NYU Langone Medical Associates, West Palm Beach, and on staff at Good Samaritan Medical Center in West Palm Beach. Dr. Selzer, I wanted to ask you, last time on the program, you told us that you did a kidney fellowship when you were up in New York. Can you tell us a little bit about it?
So yes, when all graduates graduate medical school, they start with an internship and then typically a residency. So I did my internship and residency at Westchester Medical Center. After I completed my residency training, I decided to do an additional 2 years of study at Lenox Hill Hospital in the Upper East Side, and I focused on kidney disease. And it was just a 2-year fellowship, all about all the different aspects of kidney disease. I learned a lot about dialysis, inpatient, outpatient, and I also was able to learn much about kidney transplant as I did rotations at Cornell Medical Center on the Upper East Side on 2nd Avenue.
That's impressive. And I keep on saying internal medicine internist, but you're also obviously a kidney specialist.
Yes.
And that goes into nephrology as well, which we talked a little bit about last time.
Mm-hmm.
That's fantastic.
I always view myself as an internist first because I think every good specialist always thinks about the entire body, not just one subset of it. It's good to know a lot about one thing, 100%, but it's even more important to always care about the entire person. You can't just look at just one organ and think, oh, everything, if that's okay, everything's fine. You have to know about everything.
And kudos to your chemistry knowledge. I mean, we're talking some topics on here that this is just impressive. It's got to be impressive to listen and view. I wanted to ask you, we talked a little bit about iron before the break, and now oral iron is what I think I'm more familiar with, so it's probably put in a pill, prescription, or maybe even over the counter. I take it, or subject A takes it. Now, there's also oral iron, and I want to ask you the difference between oral iron versus IV iron, because I had never heard IV iron until I asked you a little bit about your presentation.
So oral irons are given as a salt. They can be given as ferrous versus gluconate salts, and they are typically given at 325 milligrams 1 to 3 times a day. The amount that's actually active is only 60 milligrams. So therefore, our patients typically need 3 in order to help start replenishing of the amount of iron into their body. The problem is it's not so easy to take these pills. They do wonders for your stomach. And I mean wonders. They make you very constipated. They can change the color of your stool from the normal color to a very black, hardened color. And therefore, a lot of patients have a lot of difficulty taking oral iron pills. So for those patients who are diagnosed as iron deficient, we give them IV iron, and therefore it goes right into their veins, and they don't have that first pass effect of going through their stomach. Now, there's different types of IV iron. So the most common and cheapest is Infed, which is IV dextran. That can be given as just 1 shot of 1,000 milligrams, which is a lot of milligrams. Just to put it in perspective, before we were talking about taking 3 pills a day, and maybe you get to 200, maybe on a good day.
Because of 60 times 3.
60 times 3, very good. And that's on a best case scenario. Here it's going right into your veins, and voila, you're done. The problem is, and it's a little bit of a big problem, is some patients can get a fatal anaphylactic reaction. Essentially, they can their throat can close on them. So we typically give a test dose of 25 milligrams just to make sure that everything's stable and well. And then afterwards, we give them a full gram of the IV iron. Those are very good for patients who are not on dialysis, who just want to get a quick shot, get in, get out, and be done with it. And they're not having like a chronic losing where they keep losing their iron. Patients on dialysis, on the other hand, where constantly their blood is being circulated through a circuit, as we explained on the last lecture, so those patients need more chronic IV iron, and therefore we give them a little bit at a time. There's another type called furoxametil, which is significantly more expensive but can be done much quicker. Initially, it was actually approved by the FDA to be given in something ridiculous like 17 seconds. But then in practice, physicians gave it over a slower amount of time in order to stop any reactions that could happen.
Now, these IV iron fusions, are they done in the office? I think you mentioned before an infusion center that you work with, or the hospital?
So they can be given at an infusion center. That could be a private place. It could be at a hospital center where they're giving other IV infusions like gamma globins or chemotherapy.
Okay.
Any place where it's set up specifically for IV infusions. So depending on the exact medical setting, it can change. So typically, after IV iron, patients generally feel better. Their reticulocytes starts going up. They start reticulating because all of a sudden they have that iron, that substrate, in order to start making more hemoglobin. And then you start seeing a rise in your hemoglobin within 1 to 2 weeks, and patients start feeling better within a month or so. But there's always a negative anytime you're doing anything. There's always a risk. So IV iron is a great substrate, but it's also a great substrate for bacteria. So when you give IV iron, you always have to make sure that the patient doesn't get an infection. Specifically, even in the hospital, at Lenox Hill Hospital, our policy was anyone who's on any antibiotics or has any fevers cannot receive IV iron, especially in the dialysis setting, because there's too much of a risk for infection from the IV iron.
Bacteria was a topic last time as well.
Yes.
Bacteria is huge in internal medicine, huh?
Yeah, because they cause bad things to happen. We want to avoid bad things and go with the good things.
To different systems in the body. Amazing. Now, how do people typically feel after the iron IV fusion? I think you mentioned it briefly, but is it something that they can get back to quality of life? Or what I'm asking is maybe someone's driving around, they still working, in their working years, or they're still very active in South Florida. How quick can they get back to? Can you do something the same day? Can you get back to your quality of life? In most cases?
I don't think you're going to feel amazing day one.
Okay.
I think physicians are promises that, I think that's for somebody else. But I think it's slowly but surely everyone starts feeling better when they're given the right medications. Quick fixes don't really work. It's slowly but surely you start to get healthier.
Going back to the red blood cells, is there a way to build up red blood cells? As exercise help? Does diet? Does staying away from certain risk factors help? So
eating your spinach and having red meat will increase your iron, and that will increase the amount of hemoglobin in your body. For very intense trainers, people who really want to exercise, high altitudes can increase the amount of red blood cells in your body. Marathoners will sometimes run in the mountains because, remember, there's less air up in the mountainous areas. So therefore, to compensate, you start making more and more red blood cells in order to carry the less amount of air that's actually there. It changes what we call the RBC dissociation curve, and that will lead to more red blood cells in your body, and that will help you get stronger. Other ways is also giving EPO, which will increase the amount of red blood cells. Famously, Lance Armstrong and his friends were taking shots of EPO in order to increase the amount of red blood cells, increase the amount of oxygen carrying capacity, and then make them go faster.
What is EPO? I'm not familiar with that one.
So Epogen, once again, is the...
Oh, the Epogen, okay. That's just the acronym for Epogen.
Yeah,
or the
EPO.
Short, okay.
Yes.
I was like, what was he taking?
I wasn't throwing something random in at the end.
Yeah, he may have been taking some other stuff, but that's a discussion for a different day.
Discussion for another day.
Who knows? I mean, Major League Baseball too, but it was quite an era.
Yeah.
As well. Now, again, I want to give out the info. It's hard to believe we have less than 2 minutes and another fascinating talk. So, your lecture, the topic again is anemia and chronic kidney disease. It's June 27th, which is upcoming Wednesday in a few weeks. It's at Good Samaritan Medical Center, West Palm Beach. I think it's 1411 Flagler Drive. I just had their website here. And anyone can come. It's a free lecture, correct?
Free lecture, no questions asked.
Right at lunchtime, which is an easy time to get over there, get in and out of there, at noon on June 27th. So definitely check out Dr. David Selzer. He's got an internal medicine practice, NYU Langone Medical Associates in West Palm Beach, 101 North Clematis Street, Suite 110. And your phone number, 561-365-3000. Or just type up Google Dr. David Selzer. It'll come up great, nyulangone.org website there that I got a ton of info on when I wasn't Googling anemia.
Thank you so much for your time. I really
Thank
appreciate it.
you for coming back on the show. You're always welcome. I'd love to have you on. I mean, every once in a while to just talk about the latest in internal medicine, kidneys, nephrology.
My pleasure. Whenever you'll have me, I'll come.
All right. Thank you, Dr. Selzer.
Thank you.
And thank you for listening to the You and Your Doctor Show.
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV at 866-244-5422 and we will put you on the air as soon as possible. Tune in next week for more information on living longer and having a healthier life.